Hello and welcome to the DN News Network. This show is the DN Talk Show where we bring in eminent personalities in different fields. We are here with Dr. DK Satsangi, Dr. Deepak Kumar Satsangi, who is an eminent cardiac surgeon, vascular surgeon. He's at the present moment he is posted in All India Institute of Medical Sciences, Rishikesh, Uttarakhand in India, and we are here to talk to him about some heart ailments. There are many heart ailments which are prevailing in this country in various sections of the society, and we need to know about them. We need to know about how to tackle them. We need to know about how to prevent them. We need to know how to manage and how to get it treated. And most of us are ignorant about all of these things. That is why this is an awareness program that we bring about to you every week with an eminent personalities of this country and also from the foreign countries. Today we will talk about valve replacements, valve surgery, heart surgery, which is majorly done for heart replacements. Dr. Satsangi has been a director professor in GB Pant Institute of Postgraduate Medical Education and Research in New Delhi for about 20 years, and is now working as an HOD in Cardiothoracic and Vascular Sciences Department in All India Institute of Medical Sciences in Rishikesh, Uttarakhand. So we are here with Dr. Satsangi. Dr. Satsangi, can we start with the program? Can we know something about valve replacements in the heart? Dr. Satsangi, can you hear me?
I can hear you. Yes, can you hear me?
Yes, now we can hear you. Can we start the program, sir? Can we start discussing about the topic? We would just like to know something about the valve replacements.
Hello, shall I start talking or shall I wait to hear
Yes, sir.
some
Yes,
questions?
please. No, please carry on with your talk first, and then we will ask something, whatever doubts we have.
Okay, right. So at the outset, I thank you very much, Devendra ji, for taking this a very important mission of health education and educating about the various heart diseases. And in this session, we are going to discuss about the diseases of the heart valve. The heart valve diseases are very prevalent in our country, and most common cause for these diseases is the rheumatic heart disease. And rheumatic heart disease is very common in tropical countries, particularly in rural areas and among very poor populations. As we know, the poor population which lives in congested area in small houses which are damp, the houses where there is not much of light and ventilation, and so many people are living in a small room, the infection with the bacteria which causes rheumatic heart disease is very common. And the common organs of the body which are affected by the rheumatic fever, they are the joints, the heart, and the brain. And among them, the most serious involvement is that of the heart. This rheumatic fever, this affects the heart as a whole. This affects the myocardium of the heart, pericardium, that's a membrane around the heart, and the heart valve. Among all these, the involvement of the heart valve is most serious. And what happens, first of all, the heart valves get inflamed. What I mean by inflammation is that they get swollen, and later on they start degenerating. And with the degeneration, these valves are distorted. The two or three cusps of the valve, they fuse with each other, so heart valve opening becomes very narrow. Let me tell you, the prime function of the heart valve is to control the forward flow of blood through the heart. So when the blood passes through the valve opens, and when it tries to return, it closes. So it does not allow the blood to come back, and therefore the blood is pushed forward through another valve into the body. When these valves are distorted and are not functioning properly, then we call that these valves have become regurgitant. So when they try to hold the backflow of valve, they are not competent, and all the blood regurgitates back into the atrium. And this is what we call it as the valve regurgitation. The other defect, as I told you, when the valve cusps are fused. So when they are fused, the opening of the valve becomes very narrow. We call it as valve stenosis. And this checks the proper flow of blood through the valve, and therefore pressure behind the valve starts increasing. And this pressure is reflected on the lungs, and therefore lungs gets congested and patient feels difficulty in breathing. And this also causes damage to the lungs, and because of the damage to the lungs gets infected, and therefore the patient becomes unbreathable. So in short, we can say that involvement of the heart valve leads to heart failure and then ultimately death of the patient. As we know that in the heart, in the human heart, we have four chambers, the two upper chambers and the two lower chambers. Two upper chambers are known as the atrium. So we have a right atrium and we have a left atrium. And the lower chambers are known as the ventricles. So we have a left ventricle and a right ventricle. The left ventricle is connected to aorta. The right ventricle is connected to pulmonary artery. The pulmonary artery takes blood to the lungs, while the aorta takes blood to whole of the body. The wall between the right atrium and right ventricle is known as the tricuspid valve, and the valve between left atrium and left ventricle is known as the mitral valve. Again, the wall between the left ventricle and aorta is known as aortic valve, and valve between the right ventricle and pulmonary artery is known as the pulmonary valve. So we try to understand that blood from all over the body through the veins collects into the right atrium. From right atrium, it is pushed into right ventricle, and then when right ventricle into the pulmonary artery, then tricuspid valve, this closes and does not allow the backflow of the blood from the right ventricle to the right atrium, but it allows the blood from right ventricle to flow through pulmonary valve into the lungs through pulmonary artery. When blood tries to return into the right ventricle, the pulmonary valve closes and does not allow the entry of blood into the right ventricle. When it goes to the lung, the blood gets oxygenated. It is purified, and after oxygenation and purification, this blood returns through pulmonary veins to the left atrium, which is the upper chamber on the left side. And the left atrium pushes it into the left ventricle, which is the lower chamber on the left side. Then lower chamber, the ventricle contracts in order to push it through the aorta, and then mitral valve closes and does not allow the entry of blood through the valve into the left atrium, and therefore the blood takes a forward flow through aortic valve and it goes to the aorta, and from there it is distributed to the whole of body. When the left ventricle relax, blood tries to return back to left ventricle, the aortic valve closes and the blood is not allowed to enter back into the left ventricle by the aortic valve. So therefore we see what is the stenosis. So we may have mitral stenosis if it involves the mitral valve. We may have the tricuspid stenosis if it involves the tricuspid valve. May have the aortic valve stenosis if it involves the aortic valve, and we can also have the pulmonary valve stenosis if it involves the pulmonary valve. Similarly, as I said, if the valves are degenerated, if the valve becomes distorted, when the valve becomes incompetent, then they lead to valve regurgitation, and there is a backflow of blood from the lower chamber, that is ventricle, to the higher chamber, that is atrium. So again, we may have a mitral regurgitation, or tricuspid regurgitation, or aortic regurgitation, or pulmonary regurgitation. Most of the time we get a mixed lesion. That valve is stenotic as well as the valve is regurgitant. And in that case, this is a mixed lesion, and this is more harmful to the functioning of the heart. Now let us see what are the people who are involved with this rheumatic heart disease. In our country, as I said, mostly it's the poor people because we are tropical countries. Mostly it is the young people and the young females, the childbearing age group of the females. They are most commonly involved, and most common valve which is involved is the mitral valve. Most common lesion is the mitral stenosis. So the usual presentation of a patient with mitral stenosis in a hospital will be that a young female who is in a childbearing age is maybe 18 years or 18 to 25 years, and she comes with the complaints of breathlessness because, as I said, that this mitral stenosis causes pressure over the lungs. So she will say that I am not able to breathe properly. I get breathless if I walk a little or I try to do hard work. I get breathlessness. Then again, I said that apart from breathlessness, there may be involvement of lungs. So this may lead to the frequent lung infection. So she may say that it's very common for me to have cough along with expectoration, that is sputum. I get fever also, and sometimes chest pain. So this is the typical history. A young lady who has breathlessness, which is progressing, means increasing with time. She has signs of lung infection, which is the cough, expectoration, and pneumonia. Apart from that, she has tiredness, history of tiredness. She frequently becomes tired. If you further explore the study, then you find that she also has the history of rheumatic disease. The rheumatic disease is that she will say that in the past she had a sore throat, and she said, I had a bad throat, which is the infection with the beta hemolyticus bacteria, which is the cause of rheumatic fever. Then she said that I also had fleeting joint pains or arthritis, that is the involvement of the joints. She will also tell us that apart from this, I had fever, and some of them may have the cerebral symptoms also. As I said, it involves the brain as well. Now, if it comes like that, then we must suspect that this lady is suffering from rheumatic heart disease. If we examine this lady, then we will find that there are certain signs of rheumatic fever in her, that she is having the swollen joint pain or arthritis. There are certain typical nodules are present, which are known as the subnalar lodes, that is underneath the nails. So you have, and then you have erythema marginatum, that is what we call as that wherever there is junction of a mucous membrane and the skin, so they get red in color. There is typical facies also, which is known as the mitral facies, and there is malar flush. There is a flush in the on the cheeks. So these are the things which will make you suspicious that this lady suffers from rheumatic heart disease. And if you auscultate on her heart, then mainly you find there is always a murmur present. Now the murmur is a thrill kind of thing which is audible when you hear with a stethoscope. You find that there is a sound, abnormal sound there, and these sounds are different. In a case of mitral stenosis, it will be a different sound. In case of mitral regurgitation, it will be different sound. A sound of my tricuspid regurgitation will be heard in a different area. A sound of aortic valve will be heard in different area. So by hearing this murmur, we suspect that there is involvement of the heart valve in this patients. Now what we do, once we have suspected, then we have to confirm it, and then we have to do a battery of investigation. First of all, we do some blood tests, and these blood tests will tell us whether patient suffers from rheumatic heart disease or not. And these are mainly the ESR test. ESR is raised in these cases. Then blood counts, we find the lymphocytes are raised in these cases. If when we do the ECG of this patient, then we find according to the valve disease. If there is a mitral valve disease, if there is a mitral valve disease and mitral stenosis, then we have different kind of ECG findings. If there is a regurgitation, then there are different kinds of ECG findings. So we do electrocardiogram. This gives us an idea that which valve is involved and which chambers are affected. And then we do a X-ray chest also. The X-ray chest tells about the heart enlargement of the heart, what we call as cardiomegaly, a big heart. And this will also show us that which chamber of the heart is enlarged. Now, for example, if there is mitral regurgitation severe, then we find that apart from the enlargement of the left atrium, there is enlargement of the left ventricle is greatly enlarged in this case. But if it is mitral stenosis, then it is mainly the left atrium which is enlarged, which can be clearly seen on the chest X-ray of these patients. Similarly, if it is involvement of tricuspid valve and there is tricuspid regurgitation, then we find there is enlargement of right atrium, that is right upper chamber, and also the right ventricle, which is the right lower chamber. Again, as we discussed before, that there is involvement of lung also in these cases. So if we concentrate on the lung, the findings of on the X-ray chest, then we find that the lungs have got a hazy shadows are present. The lung arteries are enlarged in size, pulmonary arteries are enlarged, pulmonary veins are enlarged in this case. Then we also find that certain upper lobe veins becomes very prominent. We have ground glass appearance of lungs, and there are many more signs which are more specific, and they are important for the a clinician who is examining the patient. So once we have seen this after lung, then the another investigation which helps us is the echocardiography. Now today's time we have 2D echocardiography. This is a non-invasive investigation, and this does not involve any X-rays. All what we use is the ultrasound waves. The ultrasound waves, they are high frequency sound waves, and they are capable of penetrating the chest wall and other organs of the body, and they are reflected by the various the structures of the body. and these sounds are then collected, and then they are computerized and they produce a picture. So by doing echocardiography, we can know that what is the condition of the heart as such, and therefore what we see is that the mitral valve, we will find that mitral valve has become very thick, mitral valve is degenerated, mitral valve is regurgitating. If we use a Doppler study also, these are the two studies, echo and Doppler, they are combined together to have clear picture. The Doppler study will show us that blood is regurgitating through mitral valve. The echo study will show us the valve is thickened, the valve is deformed, valve may be calcified, the valve may be fibrosed, and the chambers are enlarged, left ventricle enlarged, right ventricle enlarged, or in case of stenosis, we find that valve opening has become narrow and enough blood is not passing through that. We may have further information also. We can see the size of pulmonary artery, which also will be enlarged by doing echocardiography. There is the back pressure, which affects the right ventricle, and then we find that right ventricle is also enlarged, the right atrium may be enlarged. So all this information we can get from the echocardiography. 2D echocardiography is a two-dimensional echocardiography, and then we also add the time mode in this patient. So this is 2D, two direction, and then we have the time mode involved with this, and Doppler added another expansion, another reamp to this investigation, and this gives us almost complete information about the valve disease. Nowadays, we have the 3D echocardiography, which gives the three-dimensional image of the valve. So if you look at the three-dimensional image, you have got a surgeon's view, as if you are directly looking at the heart valve and the heart structures during surgery, and this is more informative and very helpful in doing some interventional procedures in the heart and the heart valve. Nowadays, we have a 4D echocardiography. So there are advancements one after another, and then we go further, and then we have some radiological imaging, radiological investigations, and out of this, the CT angio has come, the cardiac angio has come, and these are the contrast study using the contrastor dye, and then they are scanned, certain scanning is done, and they give us the cut pictures, and these pictures can be computerized tomography, what we call as the CAT scanning, and this gives us the three-dimensional view of the heart structures and tell us the exactly about that which valve is involved, what is the nature of valve like that, whether this valve is repairable or whether this valve has to be replaced. This can also tell us, can we open this valve safely? Can we open it with a catheter intervention, which is nowadays known as the balloon mitral valvuloplasty, or can we do a closed mitral valvotomy, or the valve is very bad, we may have to do an open heart procedure and do an open mitral valvotomy, or it will require a replacement. Sometimes the valve is so badly damaged, most of the time, the mixed valve is, and as I said, which is stenotic as well as the incompetence, which is thickened, fibrosed, calcified, and not repairable. So we have to change these valves. And the valve implantation, valve transplantation is the only alternative which is available to us. And then further investigations which can be done in these cases is the angiocardiography. The conventional angiocardiography is done with a percutaneously. We introduce a catheter. Catheters are the long tubes, as you know, the wires which has got a tunnel inside, and this is introduced through a peripheral artery like femoral artery, which is the artery present in the groin, or brachial artery, which is the big artery at the elbow, and through that we introduce this catheter, and inside the artery itself or the vein, it reaches to the heart, and when it reaches to the heart, then we can inject this contrast a dye, as I said, and this dye will show all the flow of dye that will be depicting the flow of blood into the heart, and we can easily see that what is the flow of dye through the valve, whether this dye is regurgitating, that that it has gone into the ventricle and valve is incompetent, so it comes back to the atrium. Or we can also have some idea about the size of the ventricle. What is the size of left ventricle, right ventricle? What is the size of right atrium? And we will also have a good idea about the functions of the left ventricle. You know, the heart function is very important, and we measure the heart functions in terms of the ejection fraction. When we say the ejection fraction, it means that how much of blood which is present in the ventricle is ejected when the heart ventricle contracts one time. Normal values are more, but as the heart weakens, this starts coming down. If it has come down to 50 or so, this shows that this is the time we should intervene. We cannot let the heart functions like this because these heart functions are being damaged, and therefore we should intervene, and we have to replace the valve or repair the valve or open the valve. Whatever is required has to be done. But in case it goes down and it goes down to 20% or so, then it is too weak to stand the operation, and then we say that the operation is contraindicated in this case. So this LV functions, left ventricular function, is most important because it is systemic ventricle and it is pumping all the blood to the body in the circulation, body circulation. And so this is the angiocardiography. Another information it can give us is the coronary angiography. The same catheter which we have put into the aorta, this can be directed into the coronary arteries. As we know, these are the arteries which are supplying blood to the heart itself. And these are very important arteries because if these are affected, the patient's heart will not be able to function properly. There may be severe heart pain, what we call as angina. There may be the heart attack, what we call as myocardial infarction. This may prove fatal. So in order to know that is there any obstruction in coronary arteries, we do coronary angiography, and these catheter we introduce into the opening of coronary arteries, and we begin inject the dye, and we begin inject the dye, and by the flow of dye which is recorded on the screen through cine angiography, we can trace the whole course of the anatomy of the coronary artery and can see whether these arteries are obstructed or not blocked. If they are blocked, then what is the degree of obstruction? Whether there is a 50% obstruction is considered significant. If it is more than 50%, then we have to be little careful. If it has gone to 70 or 75%, then definitely needs intervention. But it will depend, present of symptoms also. If symptoms are present, then even 50% obstruction is significant. If the symptom is not there, we can medically treat even 75% obstruction of a single artery. But if more than arteries, usually we have the three important coronary arteries in the heart, and they are the right coronary, left coronary, and the left coronary has got a left anterior descending and left circumflex artery. So in that case, if more than one or two or three are involved, then it definitely needs intervention. Whether we are going to deal it with the balloon angioplasty and a stent, or we are going to do a bypass surgery, that we have to decide depending on the merit of the patient. But definitely we have to intervene. So coming back to the valve, we see that angiocardiography will give us some added information about the heart and about the condition of the valve. Then many more investigations have also come up, which we usually do not know, like nuclear studies, nuclear scanning, and all these things. But most of the time, the echocardiography information is enough for us to go ahead with the operation. So as I said, coming on the treatment of these patients, then what we have to do surgically, as I said, if valve is stenosed, then we have to open that valve. Now opening that valve earlier, we has a closed mitral valvotomy in a case of pure stenosis, which does not have mitral regurgitation. So closed mitral valvotomy, we used to dilate it with a dilator, and that dilator was known as Stubbs dilator. So through the left ventricle, we introduce this dilator across the valve, and then we put a finger into the left atrium through atrial appendage, and as we open this dilator, the stenosed valve or the fused valve gets open, and stenosis is taken care of, and the blood flow becomes normal. Now lately what we find, that same procedure, the valvotomy procedure, can be done through a catheter percutaneously, and then using a catheter, this can be directed into the heart across the wall, and this has got two pranks, or a balloon. This balloon can be inflated in the valve, and when it is inflated, then fused the commissures or stenosis valves get open, and patient gets relieved. So this is the second operation. Often you will go to your clinician, and he or she will tell you that your patient has a mitral stenosis, the valve is stenosed, it has become narrow, and this is the cause of all problem. If it is not taken care of early, this may prove fatal, and patient's lungs may get totally destroyed, and therefore you need a balloon valvotomy. This is what is done by the cardiologist, and therefore you can get the balloon valvotomy done. If sometimes the valve is not it's not possible to open the valve with a balloon, particularly the cases where the valve is calcified, where the valve is badly deformed. When you open, it is already there is incompetence present, the valve is regurgitated, it's a mixed lesion, or there is some clot present in the left atrium. So you may say that you need a surgery. It's not safe to go ahead with balloon. Then you may have to come to a surgeon, and surgeon, after seeing all this, will have to tell you whether a open mitral valvotomy will be enough to do it, or you need a open valvotomy along with the repair of the valves, or you may have to a valve implantation or valve transplantation. And therefore you should know that what is a valve implantation or valve transplantation. And as I say, the valve implantation means you have to implant, you have to replace the patient's disease valve, which is totally destroyed, by using an artificial valve. This artificial valve is also known as the heart valve prosthesis. These prostheses usually are of two types. They are either the mechanical prosthesis, which is made up of steel, or it is the tissue prosthesis, where the natural tissue is involved. Tissue prosthesis, again, it may be the two types. Either it is the heterograft or homograft. When I say heterograft, it means it is from other species. Mainly, what we take is the pig's heart valve. Pig's heart valve are also known as xenograft, or we can take human heart valves. They are homografts, and these valves are taken from the cadavers, usually cadavers, the dead patients, the dead people whose cadaver is utilized for taking out these homograft valve from them. And then also certain valves which can be made from the pericardium. As you said, the pericardium is the membrane around the heart, and with that you can construct a valve, and they are known as the pericardial bioprosthesis. So let us see the what kind of valve is best for the patient. Usually, as I said, first of all is the tissue valve, what we call as the pig valve or the xenograft. And this is, you take the valve, aortic valve of a pig, and then you mount it. There are certain mounts on which these valves are stitched, and then they are sterilized, and they are preserved in formaldehyde. You must be knowing the formalin is a common household chemical, a diluted format used for the preservation of these valves. So these are the xenografts, and they can be used for the replacement of the heart. Secondly, I said the valves which are made of pericardium. So you have the calf pericardium or the bovine pericardium from a cow, and then you design a valve from this on a stent. So there it is stented pericardial valve, and then again it is fixed and then preserved in the glutaraldehyde. The third valves are the stentless valve, where you don't have a stent, because this has also been found. If the valve has a stent or a stented valve, their performance is not as good as a stentless valve. So these valves are stentless valves. So you take the xenograft from the pig as such, and then you don't put any stent, and then you attach some kind of a flexible ring, and then you implant it as a this kind of valve is such. Now, so these are the tissue valves, and then you have a homograft, as I said, which you collected from the cadaver, and we will discuss it that how you make a homograft valve bank, how do you collect from a dead body or which is going through the postmortem, and how do you prepare these valves, and then we will compare that which valve is better for the patients, whether they should have a tissue valve, and the tissue valve whether they should have a pig valve, or they should have a pericardial valve, or they should have a homograft or the human valve. On other side, we talked about the mechanical valve. The mechanical valves are made up of the steel valve. The first valve which was used was a ball and cage valve, which was designed by Dr. Albert Starr, and he implanted in the year 1965. And since then, the patient we operated in 1965 did well till the almost next 40 years, right somewhere in the year 2005. So this was commendable performance. This has a cage and a ball there, and but later on it was found that it's a big valve. So in order to reduce the size of valve, the disc valve came, and first came the monodisc valve, which had one disc, and then came the bileaflet valve, which has a two disc. So up to some time, this disc valve, the bileaflet valve, mechanical valve, which is called, and its all structure is made of stainless steel, the housing structure. The valves are made up of pyrrolite carbon, which is a very smooth metal, and they used for a long time, and still they are being used, mechanical valve, because they are very durable valve compared to the tissue valve. These valves functions longer time, and one can expect that they will function not in all patients, but at least half of the patient, 50%, they will function to 20 years or more. While tissue valves starts degenerating. If we are using a pig valve, they usually go to the 5 years time. If you are using a pericardial valve, they go for up to 10 years or 15 years maximum. If you are using a homograft, they will go 20 to 25 years or so. Not in all patients, but a good number of 60 to 70% patients will live for 60 to 70% with these valves, and then it will need a change of valve again. Then another valve is known as autograft. These are the valve which is taken from the patient himself, like pulmonary valve is taken out from the patient itself and implanted into the aortic valve, and the pulmonary valve is replaced by a homograft. So this is known as the autograft or the Ross procedures. So these are the various kind of valve replacements available to us. Let me see if I have my presentation. I will try to tell you through those pictures that what do I mean when I say. Now, uh,
Sir, can we go ahead with you? You
can
need some
can
more
I have
time
my
or
present? No, I will need the presentation which I have given you.
you now want to present the
Can we
presentation,
show some
right?
slides?
Yes, okay, hold on.
A few of those slides so that I can make them aware. How much time I do have now?
Now we are sharing it. You can say no. We are now
Okay, fine.
going ahead. Hmm.
Yeah, do the
We'll speak
presentation. I'll
about
take another 10 minutes.
okay.
Yeah, please. Yes, I can see you. Are you going to show? Your mic is muted, Devendra ji.
Sir, the presentation is being, the slide is being presented there. Can you see? Can everybody see the slides? Can everybody
Hello?
see the?
Yes, yes, sir. Yes, sir. Yes, sir.
Dr. Satsangi, please carry on. This is the first slide.
Yeah.
Yes, sir.
Please
I'm not
carry
able to
on.
see. No, I'm not able to see the slides. Why? How to see the slides?
You are not able to see the slides.
Yes, sir.
Can you see me,
Yes,
Yes,
yes, we
sir.
can
Yes,
see
sir.
you.
Devendra
Yes,
ji?
sir.
We can see you, sir.
Hello?
We can see you. We can see you, sir. आप अपने को अनम्यूट कर ले सर, प्लीज अनम्यूट योर ऑडियो. हाँ, करेक्ट. चलिए, नाउ कैरी ऑन.
जी हाँ, मुझे नेक्स्ट स्लाइड दीजिए. आप बढ़ाते जाइए स्लाइड, because time is less, so I will use selected slides. Next one. Move on with the slide, please. Can you hear me? Hello, next slide. Hello.
Sir, this is the third slide.
फोन करो, फोन करो.
This is the third slide. Should I start from the beginning?
हेलो
Hello?
देवेंद्र जी.
सर, आपका स्लाइड मैंने चेंज
हेलो.
कर दिया है. ये थर्ड स्लाइड है. हेलो.
हाँ देवेंद्र जी, मेरी बात नहीं सुन पा रहे हैं ना आप उस पे?
मैं बड़ी क्लियर सुन रहा हूँ आपको.
हाँ, मैं कह रहा था कि आप नंबर सेकंड स्लाइड पे जाइए. हमारा नहीं चेंज हो रहा, हम तो फर्स्ट ही पे पड़े हुए हैं. क्या बताऊं मैं तो, आई एम सॉरी, अभी तो आई एम सीइंग द, हाँ, मुझे फर्स्ट दिख रही है, या ऐसा करें, क्या करें बताइए?
Can everybody see the slides, please? Can you respond? Can everybody see the slides?
आई एम
हाँ सर,
सीइंग द फर्स्ट स्लाइड, देन आई कैन
फर्स्ट
स्पीक
फर्स्ट
विदाउट
स्लाइड।
स्लाइड्स देन।
ओके, सेकंड स्लाइड देखिए, सेकंड स्लाइड चेंज हो रहा है क्या आपके यहाँ?
नहीं, नहीं चेंज हो रहा है, फर्स्ट ही पे है सर।
आया सेकंड
Can
स्लाइड आया
everybody
सर।
else see the second slide?
यस सर, यस सर, सेकंड स्लाइड इज देयर सर।
Now it has changed for the third slide.
आया सर, स्लाइड्स आर चेंजिंग।
आई एम सीइंग द फर्स्ट स्लाइड ओनली। दोबारा करता हूँ।
करिए।
ओके जी, हाँ मैंने अनम्यूट कर दिया। आई हैव अनम्यूटेड इट, कैन यू हियर मी? ठीक है, ओके। So where were we? Now I was talking about some artificial valves, and I talked about the mechanical valves, and I talked about the tissue valves, and the tissue valve we talked about the heterograph, which is the pig valve, and also the cow valve, which is made up of the cows or the bovine pericardium, and then we talked of homograph, which were taken from the cadavers or the dead people. Now let us analyze them, their merits and demerits. As I said, the only good point with a mechanical valve, which I told you a ball and cage valve, and I talked about a disc valve, which is monoleaflet and bileaflet disc valve. They are very durable valves, but the only problem is that there is tendency of blood clot formation on these valves. When the clot forms on these artificial heart valve, it blocks the valve completely, and this causes the sudden death of the patient. The other problem with the clot formation is that this clot gets dislodged and then go into circulation, and they block the arteries, which are important arteries, like they can block the arteries in the brain, and which leads to the paralysis of the patient, which we call as the strokes. So patient may have the left-sided hemiplegia paralysis or right-sided paralysis. Sometimes they cause even death of the patient. So this is the big problem with the mechanical valve. So in order to prevent the clot formation in these mechanical valve, these patients are put on anticoagulants, or what we call as the blood thinners, the common blood thinners. You might have read about warfarin, or you might have heard about the Sagistron. This is the another Acetrom is the drug, and these are given to keep the blood thin. And when the blood is thin, the tendency for this clot formation is less, and therefore patient can go on these blood thinners, but they have to be taken throughout the life. And sometimes there are chances that you may give overdose or you may give underdose. If the dose is less, then a clot will form definitely. If dose is more, then patient will have hemorrhage, and therefore patient will die. and bleeding, and in both ways it is very fatal. If patient, the valve gets clotted, patient dies. If the patient has hemorrhage, then it bleeds. There may be bleeding in the brain, or what we call as cerebral hemorrhage. There will be bleeding from the lungs, what we call as hemoptysis. He may be vomiting the blood. Then may bleeding in the stomach, the bleeding in the kidneys. So all kind of bleeding, this may prove fatal. So in order to see that doses are not on either side and correct dose is given, we do a test which is known as INR or PT-PT. The blood clotting time is monitored, and with this PT-PC test, we keep it between 1.5 to 2.5. This INR ratio you must have read of. Those patients who have got a valve replacements are on acetone therapy or the coagulation therapy. They do this PT test or what you call as INR test. Every 3 weekly it has to be done, and has to be kept in between 1.5 to 2.5. But if sometime patient is not compatible, this is the problem. If patient is not compliant, particularly in poor countries like India and China, they live far away from the hospital. They are not able to come to the hospital every 3 weekly. Sometimes these medicines disappear from the market or they stop taking the medicines. And in case of complications, they are living in remote places. From there, they are not able to reach the hospital in time and they die somewhere in between. Therefore, mortality in these patients who have a mechanical valve or a steel valve is very high, particularly in our country. And we cannot trust that these patients will be taking medicine at home and they will be getting their INR test PT time, which has to be done every 3 weekly. And since it is, so these are not the valve of choice for us, because though it will long for a long time, it will go, but what we find that it is very dangerous and difficult to maintain them on anticoagulants, and their compliance is very poor. Therefore, we have to think about an alternative. And I said there is a tissue valve and there's a pig valve, which is taken from a pig and mounted on a stent. This is an stented xenograft. They were used in the beginning for a long time. They're very popular because we don't have to give anticoagulants these patients. The anticoagulation, what I said, is a syndrome or warfare. They are contraindicated. They cannot be given in certain patients, like lady, a female who is a childbearing age. If she gets pregnant, then we cannot continue with the anticoagulants, number one. A patient who is having a gastric ulcer, or patient who has ulcerative colitis bleeding from the colon. In that cases, if you go coagulate, it will give terrible bleeding, and that patients may also die. So, and certain people who are in a profession where they are exposed to accident, exposed to injuries, like a policeman, a football player, or any athletes. So in those patients also, we cannot give them with a tissue valve. So in these cases, we go for tissue valves. And only good thing I said that you don't have to give them anticoagulation. Therefore, all the problems which are related with anticoagulations, like hemorrhage and bleeding and the clotting, is not present. But the problem is that these valves are not very durable valves. Most of them valves start degenerating by the 5 years, and by the 6, 7 years it has to be changed again. The second valve I told you was the pericardial valve, which has been designed from the pericardium of the cow or cough of the cow, and we think that this will last longer. And this definitely has shown better results, up to 10 to 15 years survival with these valves, and they need a change after that. But again, some of them may fail even at 10 years of time and will not go for a long time. The third valve, as I said, is a homograph, the valves which are collected from the cadaver. They has to be taken from preferably from a young man who is less than 45 years of age, who has died in less than 24 hours of the surgery, the patient who is not having probably is not affected by cancer, the patient who has not received multiple blood donation because of some hemophilia problem, the patient who doesn't have an infection, viral infection, hepatitis C, or patients with the AIDS disease. So all these things have been excluded. After that, we collect the heart of the patient from the mortuary, we bring it to our hospital, and then we dissect this under certain controlled condition in a laminar flow. Then we take out this valve, then we wash it thoroughly with saline, and then we put into an antibiotic solution which contains a group of antibiotic. It is kept for 24 hours, and then culture is taken from this and sent to the pathology lab to show whether there is any infection or not. Then they are stored in a plasma, patient's plasma, or they can also be stored in special solutions, and repeated cultures are taken. And once we find that they are free of infection, then these valves can be used for the implantation into the patients. As I say, the results are very good. We had this blood bank established in our hospital at the GB Pant Institute of Postgraduate Medical Education and Research, and this I established in 1989, and in 19 I retired in 2018. So we followed these patients for almost 30 years, and we kept on operating this into 2009 was the last patient we did. So we did this valve bank working for 20 years with us, and most of these patients did very well, and some of these patients were reoperated. I remember at least 10 of these patients who came for reoperation after 20 years of implantation, after 22 years of implantation, 23 years of implantation, and then their valve was again changed, and they got a new lease of life. So what we do that we give about 20 to 30 years, what kind of valve we use, or maybe less than that, by using the first operation. So patient on an average gets a lease of about 20 years of life. Then second operation will give him another 20 years of lease of life. And if needed, the third operation, fourth operation can be also done. So almost if patient comply with the doctors and hospital, they can live a normal life of 40 to 50 years with the repeated change of the valves. There are so many questions, but since we are running of time and there may be questions also, so I'll be happy to answer that. And as far as the presentation is concerned, as we saw because slides did not function properly because of some technical problem. So any some other times next week, maybe on weekdays also, as suitable to you, we can go through those slides and revise our knowledge again. Thank you very much, all of you, for a very patiently listening. And again, thank you, Mr. Deven Srivastava, for giving me an opportunity to share my experience with you. So I will now will be happy to answer your questions. Please carry on. Hello, can you hear me?
Yes, sir. Yes, sir.
Yeah, yeah.
Now, I would like to first thank you very much for the presentation that you have given to us and such a great knowledge about heart diseases, especially the valve replacements and the
So
problems
you are,
why a valve of the heart has to be replaced. So these are something that you have told us for some critical issues, and we need to discuss with heart surgeons and cardiac physicians also sometimes. But now, what I want to know is that you think that this valve replacement can be done in any ordinary operation theater, or it needs a specialized operation theater at every village level and every district level hospitals in India?
no, first thing I would like to say, because these are specialized operations, so preferably they should be done in cardiac theaters where heart operations are being taken regularly. Number one. Hello, can you hear me? Number two is that we need not perform right in the villages, because most of the time patient has enough time to come to the hospital, which may be present at the district level or may be present at in the metropolis, like in the capital of the states, or in metropolitan cities, like most of these are in the Delhi and Bangalore, Calcutta. Most of these hospitals are in Bombay, Chennai, and Trivandrum. So patient can reach there, and some kind of network can be developed, particularly with this telemedicine. There are centers may be established at the remote area, at the village level, or at the urban level, or district level, where doctors or physicians are there and they are connected with the telemedicine. Patients may go there, may have preliminary investigations there, like X-ray, ECG, and echo, and then they may be diagnosed, and all these data may be sent to the highly tertiary care units or the highly specialized unit, where the surgeon or cardiologist can go through these data and can tell them, yes, this patient needs an operation and such date is fixed for her. These are the preparation he has to do, and whatever the charges are there. In government hospital like GB Pant Institute, we used to do it free of cost and used to give free valve even to most of these patients. But then later on, some patients were charged very minimal, almost one third or two-third of the cost of valve only, not for the operations. Other things like drugs and diet and post-op care and the OPD care, post-operative care, were all provided free of the cost. So it was possible to the most of the poor patients who are coming from the villages in our country and can't afford these costly operations in private hospital. But they can have some consultation at private hospital also if they can afford the cost of surgery. So they can go there and get operated. So that is how a network has to be settled. And then health awareness is very important. That is what you are doing. I must congratulate you. And I wish if some patients are also hearing in it, and I'm sure at later stage you will take out your campaign to the villages, to the patient who will know about this disease, who know if they have the symptoms, may be suffering from this disease. They go to the proper center in the village or in their districts and they get themselves examined and operated and treated in time. So that is most important. Any more question?
Yeah, I want to again ask you one more thing that
Yes.
what is basically the cost of a valve if somebody wants to get it replaced? What is the cost of a valve involved?
Yeah, this is very important question. And
Yeah.
this is important from the our scenario in the setup of our country. Now, as I said, the mechanical valve, which earlier used to cost as 50,000 rupees, now the costs have gone up and they are, mechanical valve, as I said, which is not suitable for our patients. The cost has gone up to 70,000 to 1 lakh of rupees. And tissue valve, as I said, which is suited to our patients, this pericardial valve, which was earlier used to cost about 70,000 rupees, their costs have gone up to right from 1.5 to 2.5 lakhs of rupees, which is almost not affordable by the patients. Number three is that we must know, as I talked about the homograph valve, which are collected from the dead people, and here the cost involved is zero. See, patient does not have to pay for anything. These are all valves available in our country because a number of autopsies and number of postmortems are being done. They are collected from dead bodies. They function the longest. They function for 20 to 30 years. They don't need any anticoagulation. They behave like the normal valves. So if we can set up some homograph valve like this in our country, in hospitals like government hospitals, or they may be also private hospitals can also have it. So these valves can be given to these patients free of cost. They are free of anticoagulation, so further money is also not required for the management of these patients. And therefore, I think it should be encouraged. My idea of presentation was only this, because in that presentation, which we will discuss hopefully some other time, there are all problems have been discussed in detail. What are our problems of our patients with these artificial valves and how can we solve it by using the tissue valve, which is almost at no price to them, and then how can we at a very low cost, how can we develop a homograph valve bank in smaller setups also and can use these valves. So I will again say that we should encourage the homograph. If patient is going for a mechanical valve, these are costing now presently something between 70,000 to 1 lakh of rupees. And the government of India has got a Ayushman policy or the central health policy where these treatments are provided at the cost of government to these hospitals, and they pay about in Ayushman they pay about 1,20,000 to the hospital. In central ESI and the CGHS, this pays a little more. I think 1,40,000 plus the cost of well, depends what valve the patient wants to have. So this is a great help. And those patients who have a Ayushman card, or those patients who are below the poverty limit. BPL cards are those patients who have been a government service and supported by CGHS, supported by ESI. They can have these help from the government of India and the state government as well. And then there are certain philanthropic organizations also, Healthcare Foundation. They also keep on helping the patients. I know many of them who helped our poor patients, in the nick of time, and which could operate and save their lives. Yes, please.
I also want to ask you one more thing that
Yes.
in majority of cases, if we discuss about majority of cases, what is the situation? Is the valve replacement an emergent matter? If it is emergency matter, then a person coming from a village to a metropolis city and getting into a hospital, getting himself admitted to it is a very cumbersome process in India, and most of the time it involves a lot of money and financial aspects also. So I would like to know how emergent is the issue of replacement of the valve. If the valve is not replaced immediately, and how much time it takes to start the replacement, because then is have you witnessed any death in case of delay?
That is true, very true. And it is very unfortunate in our country, As I said in very beginning that mostly it is young females who are involved, or ladies are involved. And the usual tendency is to keep on neglecting and ignoring their health. And they keep on working and they don't complain about themselves. And though they are very sick, but still they keep on going till this certain days. They become only breathless, and they are not able to walk. So they have already reached to an emergency stage. And so they have to be rushed to the hospital. I actually say they have to be examined in emergency, and their operation should be taken within a week's time, within 2 weeks' time, depending on their condition, how much advanced this is. So this is one thing I must say, that emergency surgery is needed. But if it is detected in time, or the people are careful, aware of about these procedures, then they can avoid these problems. And most of the patients, they have even 1 or 2 years of time to arrange for money and to arrange for their blood and arrange for operation, and results are also going to be good. So, speaking in long and short, the health awareness and the health education will make a lot of difference, number one. Number two, as I said, that most of the patients are poor and they cannot look up to the five-star hospitals or the private hospitals, because they usually charge 4 lakhs, 5 lakhs, including the cost of valve, which is a big amount of money for a poor one. So government should strengthen, that the facilities for such operation in government hospital should be increased. I was there in GB Pant Hospital, and when I joined, this was 1983. We were doing about 20 operation in a year, which was very less number. And looking at the problem of the patient, we started increasing fast. And within 7, 8 years, we were doing about 1,500 operations, which went to 2,000 operations. By the 10 years once we have done. So now in 1994, we were doing about almost 2,000 operations, and about 70% of them were the valve replacement. So we performed about in 35 years about 45,000 operation, out of which the 30,000 were the valve replacement and valve repair, all kind of valve, mechanical valve and tissue valve. So, but that was not enough, as I said. If you look that, on an average, we are performing in our country about 50,000 of these operations in all hospitals, in a year, but which is much less because the number of patients who need heart surgery at a time is about 50 lakhs. So out of 50 lakhs, we are doing only 50,000 operation. It means others are being neglected, and they are dying an early death without treatment. So such kind of hospital have to come up. I don't know, because it needs a lot of finances providing the surgery free of cost to all the patients and to all the families. cause a big burden on the government. So I don't know if philanthropic organizations comes forward or some insurance companies come forward or the government has got some policies. They have come up with Ayushman, I do agree, and it is helping a lot of poor patients. And but I say the problem is it's a big problem, I must say. And many patients can't afford these surgeries, and they should be provided. And a network should be there, a connectivity should be there, health awareness, health education should be there. So patient can consult a doctor and go for the treatment well in time, instead of rushing in emergency. And results of emergency surgeries are also not as good as elective surgery. So I hope this answers your questions. But lot has to be done by the people, to help these patients.
Okay, one last question, because now we are running short of time also. One last question.
Yes, any
Is
more
there
questions?
anything a person can do to prevent these
Yes.
kinds of problems? Why get into valve
Yes,
replacement?
prevention is there.
Yeah. Okay. Why
Yes,
can't we
that's right. Prevention is always,
carry on, sir? Carry on. Carry on.
yes, a lot of work has been done on the prevention of rheumatic heart disease. And as I said, that number one is that somebody is asking question.
No, you can carry on, sir. You can carry on.
Hello? I can, okay. So as I said, the prevention is very important. And this rheumatic heart disease can be prevented. Number one is socioeconomic status. This is only in poor patients. So their living condition has to be improved. The condition where they are living, they should be free of dampness, they should be free of congested, there should be open rooms, there should not be so many people living in a room, there should be proper ventilation, there should be proper light in that place. Second thing, if they have got a sore throat, which is the root cause of this rheumatic fever, these patients should be examined by a doctor, they should be given antibiotic. There are prophylactic antibiotics also like erythromycin, etc., to prevent this infections. The other thing is the injection Panidura. Panidura, that's a long-acting penicillin, and it is effective for 3 weeks to 1 month. So this is injection penicillin LA12 can be given to these patients to prevent the rheumatic heart disease, at least in those patients who have suffered from rheumatic fever and have been diagnosed. So the penicillin prophylaxis is another thing which can be given. There is oral penicillin also, which can be given these patients to prevent this infection. A lot of work has been done on this epidemiology. Some screening tests also have come, the blood screening. If you do that, you will know the patient suffers from the rheumatic fever or rheumatic heart disease. Then in the screening, you can do a frequent examination of these patients who are vulnerable and patients who are subjected to have rheumatic heart disease. You can do ECG on them, X-rays, and if possible, can do an echocardiography also and diagnose these diseases in time so they can reach their proper centers and can get their treatment, whether operation or balloon intervention or whether medical treatment in time. And that is how their life can be saved. But again, I say yes, prevention is most important step, and we all have to do it.
Okay. Now we will take questions one by one from the audience who are here joined with us. Is there anybody who wants to ask any question regarding the presentation that Dr. Satsangi has presented before you about the heart problems? Is there anyone who wants to ask anything? Please go ahead. Anyone wants to ask any question from Dr. Satsangi is welcome. Please ask the question. I think there's no one who wants to ask anything because it was actually clear, very clear about what you have said, and people have, I think, understood what you wanted to convey to them about the prevention, about the commercial aspects, about other things. And thank you very much for sharing your experience.
Thank
You
you.
very
But I
much
would
for
like
sharing your
to add, uh, yes, if there are some questions, so you can ask them to send it to you. And when we have next meeting, we can take up those questions and can discuss that. Thank you
Yes.
very much, Dr. Devinder ji. Thank you
Yeah.
very much. Okay.
Thank you. Thank you very much for
Okay.
joining us here and sharing your experience on the heart problems. We really hope that people will be benefited by this lecture, and we will join you again next week on some other heart ailment which can be prevented, and people can get more and more knowledgeable about the heart problems and can do better with the management and treatment. Thank you very much for joining
Thank
all of
you.
us. Thank you very much once again.
Thank you very much, sir. Thank you.